I'm 35 and I had a lower back injury 2 years ago. And ever since it happened, the pain has been lingering. I really don't want to have surgery. Are there any treatments that could address the lower back pain without having to have surgery?
After our research, we found that there is no clear evidence for universally effective treatment for chronic low back pain that doesn't involve surgery. However, the American College of Physicians and the American Pain Society have issued guidelines for the management of chronic low back pain. First, a person with chronic low back pain should ask their physician for evidence-based material that details self-care options with instructions on how to safely remain active. In addition, guidelines state that the first line of medication for chronic low back pain should be acetaminophen, which includes Tylenol, and non-steroidal anti-inflammatory drugs such as aspirin and ibuprofen. If chronic low back pain doesn't subside with these self-care options, acupuncture, massage therapy, spinal manipulation, yoga, cognitive behavioral therapy, and progressive relaxation is recommended. Remember, effective treatment of chronic low back pain can vary from person to person, so it's always important for you to consult with your physician before starting any treatment option.
My father's 52. He has type 2 diabetes and is overweight. He also has slightly high blood pressure. Right now he's taking metformin, and that seems to control his blood sugar. He's motivated to do some physical activity, but he still smokes. The other day, he told me that he heard about vitamin E and beta-carotene helping to prevent heart disease. Is there any actual proof of this?
You're actually asking two questions. You want to know if there's evidence that taking vitamin E can help prevent coronary heart disease, or if taking beta-carotene can help prevent coronary heart disease. First, let's look at vitamin E. You mentioned that your father's a smoker. There's strong evidence that smokers tend to clear vitamin E from their systems faster than non-smokers. So even if vitamin E had beneficial effects, there's a lower chance that your father would experience them than a non-smoker. The good news is that our research indicates that there's no credible clinical evidence that taking vitamin E has any protective effects for coronary heart disease. So what about beta-carotene? There's actually a decent amount of clinical evidence that beta-carotene does not prevent coronary heart disease. In fact, beta-carotene may actually be harmful to your father. Studies have shown that smokers are at a much greater risk for getting lung cancer if they take beta-carotene than those who don't smoke. So your father may want to think twice before taking these vitamin E or beta-carotene supplements, and consult with a physician before taking any vitamins or supplements in the future.
The organization I work for is planning a screening prevention program for colorectal cancer. We're trying to figure out if there are groups of people with higher than usual risk levels. This will help us decide where we need to target our communication tools. And for this reason, we want to know if there's evidence that people with ulcerative colitis are at increased risk for developing colorectal cancer.
There's strong evidence and a general agreement in the medical community that ulcerative colitis is very closely associated with greatly increased risks for colorectal cancer. In fact, one study showed that the risk for colorectal cancer for any patient with ulcerative colitis is 2% after 10 years of the initial diagnosis, 8% at 20 years, and 18% at 30 years. Ulcerative colitis is also a subcategory of inflammatory bowel disease. Inflammatory bowel disease includes Crohn's colitis, which is sometimes referred to as Crohn's disease. Crohn's disease is highly associated with increases in colorectal cancer risk. Because of this, there's very strong evidence to support targeted communication to improve screening for individuals with ulcerative colitis because of their higher than normal risk for colorectal cancer. You might also want to consider adding individuals with Crohn's colitis or Crohn's disease to your targeted communication campaign because they have a risk of colon cancer which is about equal to those with ulcerative colitis.
I have a 6-year-old son at home. Our drinking water doesn't have fluoride because we get it from a well. I know that fluoride protects teeth, so I buy fluoridated toothpaste. I thought this was enough to prevent my son from getting cavities. Today the dentist told me that I should look for extra treatment to prevent cavities. I want to know what fluoride treatments applied to the surface of my son's teeth will best protect him from cavities.
After conducting our research, we found that there isn't any evidence that fluoride gels and mouth rinses are any more effective than using regular fluoridated toothpaste in preventing cavities. However, our research didn't show any side effects from combining these treatments, so you might consider this as an option to provide extra protection against cavities for your son. While it isn't exactly something you would apply to the surface of your son's teeth, Dietary fluoride supplements are recommended by the American Dental Association for their strong levels of effectiveness for preventing cavities, so you might also want to consider this as an option for treatment for your son. Remember, though, it's important to consult with your doctor or dentist before giving your son a fluoride supplement to make sure that you're getting the right dose for your child.
I work for an organization that wants to reduce health problems in an urban, low-income community. We are looking to increase physical activity to reduce high rates of obesity and associated health risks in this community. We want to know what strategies work to promote physical activity in adults. We're thinking of encouraging people to walk instead of drive whenever possible. We're also thinking of getting people to do more physical recreational activities. We don't have any evidence that this works to decrease obesity, but would like to bring some proven recommendations to our next meeting with our Community Advisory Committee. Do you have any recommendations?
There's evidence that increasing the number of recreational facilities and community parks can greatly increase physical activity in urban areas. If there isn't enough funding to do this, simply working to beautify and improve the appearance of existing parks and recreational facilities has been shown to increase physical activity in low-income urban areas. Studies have shown that communities can also increase the number of people that walk or ride their bike to work by improving the safety of street crossings and by adding more sidewalks. Thus, by creating ongoing policies that subsidize recreational facilities and parks, public roads projects that incorporate safe crossings and sidewalk space, there's evidence that urban communities can increase the number of physically active individuals in the community and decrease obesity.
The hospital I work at is trying to reduce the number of adverse drug events in our inpatient population. To do this, we've been thinking about implementing a medication reconciliation process for each patient using our electronic medical records. But my managers want to know that there's hard evidence that such a system would in fact reduce the adverse drug events and errors. Is there evidence that such a system would have this effect?
Randomized controlled trials in support of a particular hypothesis are often held up as the gold standard in clinical evidence. A study on medication reconciliation using a type of randomized controlled trial called cluster randomized controlled trials showed clear evidence of the benefits of incorporating medical reconciliation into electronic medical records. This study provided quantitative evidence that moving to a provider-led electronic medical record medication reconciliation system is effective in reducing adverse drug events. This study also highlighted how the degree to which software for medication reconciliation is integrated into existing electronic medical records is a critical component in its eventual success. This was further evidenced in a systematic review of recent research that concluded that the sophistication of the information system, how it defined adverse drug events for reporting, and the detection methods it used for adverse drug events were critical factors to consider when choosing a system to implement. In conclusion, current research supports moving to electronic medication reconciliation processes that integrate with electronic medical records to reduce adverse drug events. However, careful planning, implementation, and ongoing evaluation of the system is necessary to ensure the best quality of care and the use of resources after the system goes live.